Thank you, Subhash, for inviting me to present at the Criticare update for the AMRI Hospital Postgraduate Education Service. My name is Bala Venkatesh. I'm a professor of intensive care based in Australia. And I'm originally a graduate from Christian Medical College, Vellore, and I'm very pleased to be interacting with colleagues from India. And the focus of my presentation today is the role of corticosteroids in respiratory infections, with particular emphasis on COVID-19, because we conducted a large international trial involving centers in Europe and in India, and there was a major contribution made from Indian sites. So I think it's important that that there's an opportunity to report the results of that. So as part of this exercise, I would be looking at how steroids began to be used in respiratory infections, and then steroids in coronavirus pneumonias, and then particularly the rationale for steroids in COVID, the results from the clinical trials, and particularly the COVID steroid 2 trial, which is what I'm going to be reporting on. Now, these are my disclosures. And particularly in relation to trials, I was on the management committee and the writing committee of the REMAP-CAP trial, which was published in JAMA, and I was on the management committee of the COVID steroid 2 trial, which is also published in JAMA. So the first question is, looking at the evolution of evidence for steroids in respiratory infections. So going back to 1951, this was the first paper which looked at cortisone in patients with acute streptococcal sore throats and the role of cortisone in the resolution of infection and post-streptococcal complications. This was conducted in an American military barracks in about 174 patients. And as you can see there really was not a big difference between the control arm and the cortisone arm with respect to symptom resolution. However, the patients, this trial rather was widely touted as being in favor of steroids, mainly because the sore throat seemed to resolve faster in the steroid arm as compared to the others. And so for this reason, people began to routinely use corticosteroids in respiratory infections. Over the next 30 years, there were some reports of evidence of benefit in bronchiolitis. Then, of course, we know that it's very well used in asthma and in patients with COPD. And there's some variable evidence in patients with RSV infections and aspiration pneumonia. There was then a landmark paper in 1967 in the Lancet, which looked at which reported on acute respiratory distress in adults, which is the first publication of the ARDS syndrome. And then in 1990, this was the other landmark paper, which really looked at corticosteroids in interstitial lung disease, interstitial pneumonitis, and looking at pneumocystis pneumonia, and where there was clearly a benefit in relation to oxygenation and survival in patients assigned to corticosteroids as compared to placebo. So the question then was, there really was evolving evidence in obstructive lung disease, possibly in upper respiratory infections, and then in interstitial lung disease. And what about in parenchymal lung disease? What was was there a role for steroids, and really does it dampen the inflammatory response, and does it reduce the lung injury, and does it reduce the progression to ARDS? And this was the paper in 2005, which by Confalonieri and the group with Umberto Meduri, and where there was it's a small study where they looked at hydrocortisone infusions and compared with placebo. And as you can see, patients with receiving corticosteroids had 100% survival, whilst those assigned to placebo, there was a 25% mortality by about day 30. And so, I mean, the results were really far too good to believe. And of course, the limitation was it was a very small study. So subsequent studies really have not resulted in the same evidence for corticosteroids in pneumonia. And these are the results of a meta-analysis overall, where the risk ratio really is there really is no evidence of treatment effect for corticosteroids, and the point estimate, as you can see, crosses the midline. I was privileged to lead a large trial of corticosteroids in septic shock, the adrenal trial, which was published in the New England Journal of Medicine in 2018. Now, in that trial, what we looked at was the role of steroids in a number of subgroups. And when we looked at pulmonary sepsis, which is the primary site of infections, again, as you can see there, there's really no difference. The mortality in the corticosteroid arm was 30%, 30.4 versus 30.2 in the control arm, and there really was no treatment effect with corticosteroids. So we couldn't find any evidence in a large international blinded randomized controlled trial in patients with pulmonary sepsis and septic shock. Now, so that takes me to the next question: what about steroids and viral pneumonias? Again, the evidence base is limited. There aren't many studies. Most of them are observational, some are retrospective, and very few RCTs. This paper I want to show you, which is published in Critical Care in 2019, which looked at the effect of corticosteroids on mortality in patients with influenza pneumonia. And in fact, the point estimate favors the placebo group or the control arm, and the mortality was higher in patients receiving corticosteroids. So clearly, there really was no evidence in patients with influenza pneumonia. Now, what about coronavirus pneumonias? So this is so the first coronavirus pneumonia pandemic we had was a SARS epidemic back in 2001, and where they reported a trial of high-dose pulse versus non-pulse corticosteroid regimens. And the second one was corticosteroid in patients with a MERS syndrome, published in 2018 by Arabi et al. And Yassine Arabi was, in fact, one of the collaborators in the adrenal trial I spoke about before. And basically, the key message from those two studies were that steroids really did not make any difference to patient-centered outcomes in those two trials. And there was perhaps a delay in viral clearance in patients receiving corticosteroids as compared to placebo. Now, come COVID-19, people again began to use steroids in that because there was evidence of a hyperinflammatory state, a cytokine storm, and a third of the patients had circulatory shock, and lung CTs suggested an ARDS type of picture, and therefore people felt that there's sufficient justification for using corticosteroids. And in 2020, at the height of the pandemic, based on an observational study from China suggesting benefit, 4 RCTs were conducted in a rapid time frame and then reported very, very quickly after that. The first was the recovery trial, as most of you would be familiar with that, published in the New England Journal of Medicine. The second was and that was in all hospitalized patients. The second was the REMAP-CAP trial, which was published in the JAMA, and I was part of the writing committee of that trial. The third was the CODEX trial from France, and from Brazil, and the other one was the French trial, which looked at hydrocortisone and 21-day mortality. Of these 4 trials, the recovery was the largest and was very influential in clinical practice, and it clearly showed that in patients receiving oxygen, there was clear evidence of benefit with dexamethasone as compared to those assigned to usual care. And if you look at it here, the overall point estimate, which includes all patients. But those on oxygen, there was a significant difference in mortality, and then and particularly in those on invasive mechanical ventilation, there was almost a 12 percentage point reduction in mortality. And the number needed to treat was about, if you treated every 8 patients, you would get you would save 1 life. The other 3 trials also came with they did not come with the same level of, I guess, the message was similar, but they did not have the statistical power to generate the same level of significance. But nevertheless, all of these were combined into a WHO meta-analysis, and overall, there was evidence for corticosteroids in patients with COVID-19. Now, one of the things to remember is the recovery trial it was conducted in a rapid time frame during the pandemic under extremely difficult circumstances, and therefore the investigators must be commended on doing the trial, a fantastic trial. It was an unblinded study. The decision on post-randomization treatments like ventilation, they were all left to the treating clinician. I'll show you the significance of that in a moment. They did not report data on shock. And importantly, 2/3 of the patients who died, who were not on mechanical ventilation at randomization, did not receive mechanical ventilation. And that is an interesting point which they did not comment on either in the main paper or in the accompanying editorial. So this is what I'm talking about. So this is the table 2 from the main paper. And if you look at the table, the secondary outcomes, and these were in patients who were not mechanically ventilated at the time of randomization. So the total number who died were 1,214, which is 387 in the dexamethasone group and 827 in the usual care group. And the total number who received mechanical ventilation was 102 plus 285, that's 387, which means that nearly 2/3 of the patients who died did not receive mechanical ventilation, and where the primary problem is one of respiratory failure. So this is an issue which, of course, has not been addressed in detail. Now, a number of other questions came up as part of the recovery trial or the entire steroid set of trials, really in terms of what's the optimal dose of corticosteroids, and are there differences between the ARDS subphenotypes? Is there a role for tapering, and are there any adverse effects? The steroid initiation and dosing should be based on clinical response or biomarkers. And so we looked at one particular question, and that was because the recovery trial used 6 milligrams. And the question really was, would a higher dose be beneficial? Because in early 2020, this trial was reported in the Lancet Respiratory Medicine, where dexamethasone 20 milligrams was shown to improve day 60 mortality in patients with ARDS. And therefore, the question really was, is there a role for a higher dose of dexamethasone? And certainly the concerns at the same time about using a higher dose was because there was the reports of mucormycosis epidemic in a number of places in India. So we undertook a trial called the COVID Steroid 2 trial, which was looking at higher versus lower dose of dexamethasone in patients with COVID-19 and severe hypoxia. And this was led by the Danish group and by the George Institute for Global Health in Sydney and New Delhi, with whom I have an affiliation. And the aim was to really look at the efficacy and safety of higher doses of dexamethasone in hospitalized adults with COVID-19 and severe hypoxia. And the hypothesis being a higher daily dose of dexamethasone as compared to the standard dose would increase the number of days alive without life support at 28 days. These are the study sponsors, as I mentioned. The funding for the study was from Novo Nordisk and the Rigs Hospital in Copenhagen. The trial was design was informed by a survey that we conducted post-recovery, because we were originally doing a trial of low-dose hydrocortisone versus placebo, but after recovery was published, we had to stop the trial, and we asked all the investigators about if we were to do a future trial, what corticosteroid would they use, and they said dexamethasone. There was certainly equipoise about the dose preference. 56% preferred 6 milligrams, and more than a third preferred doses greater than 6 milligrams, and most were comfortable enrolling patients into a 6 versus 12 dose comparison study. So the trial design was an investigator-initiated, pragmatic, blinded, parallel group RCT, conducted in 4 countries, Denmark, India, Sweden, and Switzerland. And we looked at all adult patients greater than 18 years of age with confirmed SARS-CoV-2 infection, requiring either supplementary oxygen of more than 10 liters, or non-invasive ventilation, or invasive mechanical ventilation. And patients with, who had received steroids for more than 5 days, or those with active fungal infection or TB, or known hypersensitivity to dexamethasone in pregnancy were excluded. The treatments were the dexamethasone or betamethasone, and we discouraged all immunosuppressive agents, although after the REMAP-CAP preprint, we allowed the use of tocilizumab. It was a blinded trial and with allocation concealment, and the duration of trial intervention was for a maximum of 10 days from randomization or until hospital discharge. And the randomization was password protected on a web-based interface and stratified by trial site, age greater than or less than 70, and use of mechanical ventilation at the time of screening. And the trial oversight was from by CRIC for all the European sites, and by the George Institute for the sites in India. And we had a pre-specified data monitoring plan, a source data verification plan. We had ethics approval for all sites pre-enrollment, and we also had HMSC approval for sites in India, and the consent procedures were as per local jurisdictional requirements. The primary outcome was the days alive without life support at 28 days after randomization, and we had a whole raft of secondary outcomes looking at mortality at 28 days and 90 days, and serious adverse reactions, which looked at septic shock episodes and fungal infections and GI bleeding. And the power calculation was based on 28-day mortality. We had 85% power to detect a 10% reduction on the primary day primary outcome, and a sample size of 1,000 patients, 500 in each arm. The protocol and the statistical analysis plan were published prior to database lock, and we had an independent data safety monitoring committee. And there was an interim analysis completed after the first 500 patients had been followed for 28 days. And the recommendation was to continue without modification. These were the key study dates, which commenced on the 27th of August, and the last enrollment was on the 20th of May. We locked the database on the 23rd of June, and we got a manuscript within 4 weeks and published at ESICM and critical care reviews shortly thereafter. So these are the results. We screened 1,400 patients and we randomized 1,000 patients. As you can see, 491 were included in the dexamethasone 6 milligrams, and 491 on the 12 milligrams and 480 the 6 milligrams. And the importance of this slide is that 2/3 of the patients, about 60% enrolled in European sites, and about close to 40% in India. And I think these are, that's wonderful because the results are generalizable because they were enrolled in different healthcare systems. The baseline characteristics, the coexisting illnesses, the time from symptoms to randomization, the trial interventions and concomitant interventions were similar between the two groups. The primary outcome was days alive without life support, and that's the heat map. the greater the area in the blue, the better it is. And as you can see, the dexamethasone 12 milligrams was clearly they had more days alive without life support as compared to the 6 milligram group. And the p-value was just shy of statistical significance at 0.07. There were no differences in the subgroups between, we had a number of pre-specified subgroups, and there were no significant differences. At 90 days, again, the days alive out of hospital was 14 days more and the 12 milligram group as compared to the 6 milligram group. If you look at the Kaplan-Meier curve, the probability of mortality at day 90, at day 28 and day 90, the curves clearly separate after almost 10 days. And at day 28, there's a difference of about 5 percentage points, which is maintained all the way at about day 90. And as you can see there, the 99% confidence intervals are -11 to +2 with a mean difference of with an absolute difference of 5%. So which means that you have a 11% greater risk of greater chance of survival if at the 12 milligram dose, or a 2% higher chance of dying with the 12 milligrams as compared to the 6 milligram group. So clearly the results, although not reaching statistical significance, the confidence intervals are in favor of the 12 milligrams. And the same that we see with the 90-day mortality. And importantly, the serious adverse reactions were similar between the two groups. In terms of septic shock, fungal infection rates, and severe GI bleeding. So the statement of principal findings, dexamethasone 12 milligrams versus 6 did not result in statistically significant more days alive without life support at 28 days in patients with COVID-19 and severe hypoxemia. There were 5 percentage point absolute risk reductions in day 28 and day 90 mortality with 12 milligrams, but did not result in 6 milligrams. There were no differences in the serious adverse event profile between the 12 and the 6 milligram groups. It's a blinded RCT with few violations. 97% of patients analyzed and followed up to day 90. There were enrollments in Europe and India, which increases the generalizability. And we had a pre-specified statistical analysis plan published before database lock. Among patients with COVID-19 and severe hypoxemia, the 12 milligrams per day of dexamethasone did not result in significantly more days alive without life support at 28 days. However, the trial may have been underpowered to identify an important significant difference. So the key questions really are possibility of a type 2 error, and hence the false negative result because of underpowering. But overall, the COVID steroid 2 trial results are most compatible with benefit from dexamethasone 12 milligrams as compared to 6 milligrams. And we then followed up with the Bayesian analysis, and I'll show you that in a moment, which was again a pre-specified one. A prospective meta-analysis is in progress, and a day 180 mortality and a health-related quality of life of COVID steroid 2 is also in progress. So the results were published in JAMA in January this year, and this was the pre-specified Bayesian analysis of the COVID steroid 2 trial, which was also published earlier this year in Intensive Care Medicine. And again, as you can see there, this is the absolute risk reduction and the absolute, this is the reduction in mortality here, and both favoring 12% as compared to the 6. So I would like to thank you all for your attention. I want to thank all the patients and the relatives who took part in the COVID steroid 2 trial, the staff in Sydney and New Delhi, and the CRIC staff in Copenhagen, all the site investigators and the research staff, the monitoring team, the clinical staff, and the funders, and the ethics committees and the legal departments. And this was the team that I was privileged to work with. And the principal investigator, Marie Munch, and supervised by Anders Perner. I was the other senior investigator on the trial. Our colleagues in India, led by Sheila Maitra, who is now the president-elect of the Indian Society of Critical Care Medicine. And then we had Professor Vivek Jha from the George Institute in New Delhi. And we also had Bharat Kumar from Apollo in Chennai, and Naomi Hammond from the George Institute in Sydney. And thank you all for your attention. And once again, Subhash, I would like to thank you for undertaking the postgraduate training and running these lectures. And if people would like to have any questions, they can write to me by email. Thank you.